Please stand by. Well, good day, ladies and gentlemen, and welcome to the Alliance to Reduce Disparities in Diabetes National Webinar, Pathways and Possibilities. Today's conference is being recorded, and now I will turn the conference over to Dr. Noreen Clark, Director of the Alliance's National Program Office. Please go ahead, Dr. Clark.
Thanks very much to all of you for joining us today. We're going to focus on pathways and possibilities in healthcare reform for reducing diabetes disparities, and we're going to look particularly at local programs that have potential for national impact. As the Director of the National Program Office for Alliance, I'm really pleased to share with you the important work that's going on at the community and national level to close this wide and growing gap in diabetes outcomes between low-income and minority populations and the rest of Americans. Before we start out, I wanted to especially thank the Merck Foundation for its continuing support of the Alliance and for sponsoring today's webinar. Obviously, there's a lot to sort out when it comes to what's next for healthcare reform, especially with the layer of sequestration that was laid over these efforts as of today. There are a lot of decisions that have to be made as we all try and move forward in such uncertainty. For example, the expansion by states of their Medicaid programs, health insurance exchanges, lots of questions. So we're particularly fortunate to have with us today Susan Dentzer, who's Editor-in-Chief of Health Affairs, the leading journal of health policy thought and research in the country. Susan's one of the nation's most respected health and health policy journalists, and you've probably heard her often on National Public Radio and seen her on the PBS NewsHour. Susan, among many accolades, is also a member of the Institute of Medicine. We also have with us today three of the Alliance leaders of local programs who are going to share their experiences in implementing innovative health system changes, specifically directed towards improving diabetes outcomes. With us is Dr. Jeff Brenner, who is the Executive Director of the Camden Provider Coalition. Dr. Brenner's work for the Alliance focuses on building the capacity and the systems that allow communities to share health data. Dr. Marshall Chin is the Richard Perillo Family Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago. The Chicago Alliance is focusing on building connections between clinical and community programs to strengthen patient engagement and improve diabetes care. And with us also is Dr. Jim Walton, who's recently taken on a new role as President and CEO of Genesis Physicians Group in Dallas, Texas. Prior to this, he was the Vice President of Network Performance for the Baylor Quality Alliance, which is part of the Baylor healthcare system. And the Dallas Alliance team is focusing on incorporating community health workers into clinical teams in a way that makes optimum their effectiveness and enhances the quality of care to diabetes patients. So the agenda for today, next slide, is the little bit of background on the Alliance, and then we'll ask Susan Dentzer to talk to us a little bit about where we stand with the Affordable Care Act and some of the issues related to health care reform. And then Susan's going to have a conversation with Jeff and Jim and Marshall about how their work at the local level can help inform this larger health reform effort related to diabetes disparities. And then we'll have a question and answer period where we hope you will all join in. If you'll send your questions to me, then we will try and cover them today. Should for some reason we not be able to get to your question, then we'll email you later this week, so we'll at least have a response from us about your query. So let's have the next slide, and what I'd like to do is give you a little bit of a sense of the effort that comprises the Alliance to Reduce Disparities in Diabetes. We're really trying to change the outlook for those who experience the worst outcomes in diabetes. In 2009, a national program was launched, supported by the Merck Foundation, and it comprises local level demonstrations, and these are located in 5 communities: Camden, New Jersey, Chicago, Dallas, Texas, the Wind River Reservation in Wyoming, and Memphis, Tennessee. And you'll be hearing a little bit from some of the leaders of these local efforts. There's also a national level initiative that's designed to support key partners who are working in diabetes control and who are specifically interested in reducing disparities. And also at the national level, the Alliance has put forward policy considerations that have been informed by local experience. Next slide, please. So at the local level, through the kind of work that you're going to be hearing about this afternoon, the Alliance is focusing on evidence-based, community-focused interventions designed to enhance the quality of care. And that is at the system level, at the clinical care provider level, and also at the patient level, primarily through patient education and self-management support systems. At the local level, there's also an emphasis on ensuring that successful programs and services that are introduced are sustained in policy and practice. So there's a concerted policy change dimension at the local level involved in the Alliance's work. Next slide, please. And at the national level, what the Alliance has been trying to do is leverage what's being learned locally to address health system provider and patient needs. And so there has been a careful effort, including involving national leaders and state leaders in looking at the kind of policies that could make a change at the community level where the people who have the greatest burden of disease are to be found. And these policy considerations have tried to consider the systemic and structural barriers that exist to providing effective care, which includes realigning financial incentives. And so we've posed a series of questions around the need to realign financial incentives. There are 6 that I want to call your attention to. One is to encourage greater integration of public health and healthcare systems to close the gap between the clinical setting and the community, to find ways and to support the sharing and reporting of community-wide health data so we can get away from the silos of information that exist in communities and achieve more comprehensive, accurate views of population health. And eliminating incentives that really encourage underinvestment in low-income, high-risk patients, which I'm sure everyone on this call knows are the most burdened patients and the most costly. We're also putting forward for consideration ways to address clinical provider needs, including finding ways to make Optimum the accountable care organization's abilities to reduce disparities, to close this gap between what happens clinically and what happens in the community, and to support the deployment of community health workers. Related specifically to patient needs, the Alliance policy considerations include enhancing diabetes self-management supports, recognizing that the day-to-day manager is the person with the condition, and there needs to be a support system around that person so he or she can function optimally. So let's move now to a new slide, and to you, Susan, to help us figure out, no easy assignment, how it is that we should be thinking about healthcare reform and what the possibilities are for finding ways to reduce diabetes disparities.
Thank you very much, Noreen, and hello to all of you in the audience today. Thank you for joining us, and thank you for having me here to moderate this portion of the webinar. So to go to my first slide, as we well know, provisions of the Affordable Care Act do really present an opportunity to radically improve care coordination in our very fragmented system and to reduce disparities in care across the board, not just for those with diabetes, but for those with multiple conditions. So an important question to ask, especially on the day one of sequestration, is which ones of these are moving forward and which are not. So let's go to the next slide. Of course, we know that health insurance coverage expansion will begin in January, just 10 months or so from now. The open enrollment period obviously begins in October, so we'll begin to get a sense very quickly how extensive coverage expansion is likely to be, at least in year one. Overall, as we know, once fully phased in, about 30 million more people in the country will have the opportunity to gain coverage through private insurance or through Medicaid, and the private insurance piece obviously supported for many people with federal subsidies. Also, as we know, a number of important insurance reforms will take effect. Most importantly, the ban on pre-existing condition restrictions being held against people either for purposes of enrollment or for coverage once they are enrolled. And then finally, the Medicaid expansion portion of the Affordable Care Act. And we now know that 26 states have signaled that they will move forward with that Medicaid expansion. 9 are weighing their options, and 15 states so far are opposed to that. And of course, as we know, the Supreme Court decision essentially made the Medicaid expansion optional, and we now know that we're going to have a number of natural experiments that will unfold as we see what happens in the states that have will not expand their Medicaid programs versus those that will do that. To move to the next slide, we know also embedded in the Affordable Care Act was the National Diabetes Prevention Program, a public-private partnership designed to bring to communities evidence-based lifestyle change programs for preventing type 2 diabetes, and that is indeed moving forward. Next slide. We also have the Prevention and Public Health Fund that was created under the Affordable Care Act. That was begun at $500 million in the first year. It was designed to build with contributions of $2 billion a year for a total of contributions of $10 billion over 10 years. That was the original design. However, the fund was reduced in budget actions undertaken in fiscal 2011 to $6.25 billion and then ultimately to $3.75 billion over the course of the decade. So essentially the allocations to be put into that fund were drastically reduced. In addition to that, a significant proportion of the fund, unfortunately, has been used to supplant some of the existing federal funding in other prevention and promotion initiatives. So it's really been used to kind of backfill the CDC's prevention and promotion budget in some respects. So on net, frankly, it hasn't amounted to nearly as much as the proponents of the fund had hoped. And of course, with sequestration now and a prospect of further budgetary changes over the course of this year, it may well be that further cuts lie ahead. Next slide. a little bit more happily, payment and delivery system reforms in the Affordable Care Act continue to roll forward. As we know, all of these are really aimed at key aims of increasing care integration and reducing fragmentation, also realigning financial incentives affecting patients, providers, and systems to accomplish other goals, importantly to support enhanced primary care, certainly to support patient self-management, and obviously concentrate on the most effective evidence-based care where possible. And to move to the next slide, we see these cropping up in a number of forms now. First of all, the patient-centered medical homes, now quite widespread across the land through an all-payer national pilot of those. 25 states have now incorporated patient-centered medical homes into their Medicaid programs. We have a separate federally qualified health center demonstration on advanced primary care, which is the same thing, the patient-centered medical home concept. We have accountable care organizations, as Noreen mentioned. We have nearly 300 of those now in the Medicare program with in excess probably of 5 million beneficiaries likely to be attributed to those ACOs over the course of the next year. And then we also have Medicaid ACOs forming in a number of states, Minnesota, Colorado, Oregon, and Washington for starters, and other states now actively exploring them. To move to the next slide, we know a lot of this is supported by something that predated the Affordable Care Act, which was the passage of the high-tech law inherent in the stimulus law that was passed in 2009. And so with the spread of meaningful use incentives and the concomitant spread in electronic health records, we are improving the connectivity of the system. Importantly, though, we are just beginning this piece of connecting healthcare systems with public health. In some communities in the country, that's very advanced. In others, it's just now beginning even to be talked about. And then, of course, we need hubs to connect all of the EHRs and other systems, and that's Health Information Exchange. And again, that's overall moving slowly across the country. In some areas very advanced, in others just slowly picking up steam. But I think on balance it's safe to say that is moving forward. Next slide. Noreen mentioned the Alliance's very important efforts to support the use of community health workers. They were also, of course, recognized in the Affordable Care Act. There is no specific financing or reimbursement mechanism created to support them, however. Nonetheless, we do see growing use of these community health workers, and just to call out one example, in Vermont, which pre the Affordable Care Act had put in place its Blueprint for Health, which essentially was its roadmap for advanced primary care practice, patient-centered medical homes across the state. And community health workers are core members of the community health teams inherent in those patient-centered medical homes. Vermont has also been one of 6 states to just recently have received the State Innovation Model grants out of CMS, which now give it the opportunity to extend the Blueprint model more broadly, and other states are following suit. So, on balance, we have some very important things moving forward, others not moving forward so quickly. And I'll just add one other that really comes up in light of recent developments after we put these slides together. As we know now, we have this very interesting study out of PLOS One about the potential very tight linkage between sugar and diabetes, and sugar consumption and diabetes. That's the kind of thing now that you would want to throw a fair amount of resources at, say at the federal level, through NIH and other places, to test out the durability of those linkages and see whether it is as simple as radically reducing our sugar consumption as a way of preventing diabetes. In the environment of sequestration, where NIH is facing a 5% budget cut, obviously ability to undertake those kinds of rigorous studies might be more limited. So that's just another thing to put on the table of concern for all of us who care deeply about this subject. So with that, let us turn to our discussions of how these efforts are really playing out at the community level. And we're going to start with Jeff Brenner, who's going to be focusing on the role of shared community data, that very important piece of the Alliance's strategy that Noreen mentioned earlier. So Jeff, let me turn things over to you.
Susan, thank you so much. I appreciate it. My name's Jeff Brenner. I'm a family doctor in the city of Camden, New Jersey. It's right across from Philadelphia. It's currently the poorest city in America and also the most dangerous city in America, but it turns out to be a great place for healthcare innovation because no one is fighting me over the opportunity to do work here. Most patients don't leave the city for care, and we've got 2 hospitals and 3 emergency rooms and about 15 primary care practices here. It's a city of 79,000 people, so the size and scale of the city actually make it a really good place to do healthcare innovation. Our vision, I'm the executive director of the Camden Coalition of Healthcare Providers. We've been around 11 years, and our vision is to make the city of Camden the first city in the country to bend the cost curve while improving quality. Because we think if the poorest city in the country does it, it makes the rest of the country look silly and points out that this problem is a political problem and not a technical problem. Our mission is very healthcare delivery focused. We are not a public health organization, and our focus is to improve the quality, capacity, coordination, and accessibility of the healthcare system. We have 50 staff, about a $4.8 million budget. We are a membership organization with patients sitting next to hospital executives, sitting next to primary care providers. In 11 years, we've made all decisions by consensus. We've never had a split vote, which is a lot of work, as you can imagine. We have a mix of foundation, federal grant funding, and hospital support. Our activities include currently running a regional health information exchange, running a fairly sizable care coordination initiative focused on very complex, high-cost patients, a lot of primary care redesign deep inside of primary care offices, working with communities around the country to figure out what's the curriculum for this kind of work, a lot of data analysis and data research to push data models for this work, and advocacy and policy change. Our theory of change at this point, which is after many years of trying to figure this out, is that I can't fix anything in healthcare if I don't cover 3 areas. Data, and that's real-time data feedback, feedback loops at the patient level, and using data in much more dynamic ways, and not segmenting data by diagnosis, but by complexity and utilization. Clinical redesign, which is MBA-level process redesign. It's a fundamental rethinking of workflows and how re-engineering how delivery systems work. And very deep engagement with patients as partners in goal setting, engagement with providers in very new and different ways, and engagement with hospitals, and engagement above us with Medicaid director and our state officials and federal officials. On to the next slide. I want to talk briefly about a case to give you a sense of the kind of work we do. It was a 64-year-old African-American male with COPD, diabetes, prostate cancer, laryngeal cancer, and uncontrolled high blood pressure. This is a dual-eligible patient that lives with his wife, so that means the patient is poor and is eligible for both Medicaid and Medicare. In America, that's the most expensive subgroup for health care. The patient is on 2 insulin injections daily in addition to 17 other daily medications, and in 6 months prior to our intervention had 3 admissions in a 1-month period, which triggered our picking the patient up. So we identify patients through real-time data coming through our health information exchange, and every morning we print out a report that's a citywide hospital census with a combined view of health utilization from all 3 hospitals. At the time we did this, there was not a commercial product available to do it. So we download raw data into Microsoft Access, and we have a 25-year-old graduate student crunch it up in Microsoft Access and print out this report every day. Since the intervention, the patient's only been back once, and the core of our intervention is going right up to the bedside, building a relationship with the patient when they're in the hospital, which is a teachable moment, following them out of the hospital, going to their home, and going with them to their primary care appointments. The team that did this is an embedded team, embedded inside of a primary care office, and much of their work in the last year has been redesigning workflows that many of the failures in primary care, and frankly the failures for a lot of public health interventions, is not to be very, very intentional about who are we targeting and what are the workflows that we want. And I'll get back to that in a second. So on to the next slide. I want to talk about a care map for this patient. So we believe deeply in visualizing data, and this is the care circle around this patient. Our job was we picked up the patient in hospital number 1. The patient went out to subacute rehab, and we needed to coordinate home nursing, home PT, transport, meals, variable medical goods. We went with the patient. We're embedded in the primary care office and helped to coordinate cardiology, endocrinology, pulmonology, urology, oncology, and surgery. So tremendous amounts of complexity. And this in one slide summarizes the drivers of the long-term federal debt. The bulk of the federal debt going forward is healthcare. And in this one slide, what you really see are all the silos of healthcare. And the problem is the doctors in each of those silos don't know how to talk to one another. They don't know how to collaborate. They haven't been taught. They haven't learned how to do that. They don't have the culture for that. And they certainly don't have the teams for that. And they're not paid in any way to do that. And even if we change the payment mechanisms, they wouldn't know what to do. So we have a deep and profound problem of collaboration within healthcare and shifting culture and language in the way we talk about this, not to mention the data piece and the payment piece. On to the next slide. I want to introduce you to the patient. And the person on the right here, this is a graduation diploma for the patient. And we graduate people after 30 to 60 days. And the hero here is the person on the right. Her name is Michelle Hassett. Michelle is an AmeriCorps volunteer, like Teach for America, and she's just out of college. And she's contemplating, many of our AmeriCorps participants are pre-med, pre-nursing, pre-public health. And we train them as health coaches, and extensive training and extensive oversight. They work very closely with our nurses. But the key principle that we've learned is that all of this work needs to be delegated, delegated, delegated. And doctors don't like to delegate to nurses. BSN nurses don't like to delegate to RNs and LPNs don't like to delegate to health coaches, and no one is comfortable delegating. And delegating requires standardization, protocolization, and very structured training processes so that everyone at every level can be confident that what they're expecting to be done is actually being done. Go on to the next slide. I want to make a few closing remarks about lessons we've learned, and these have been hard-won lessons. You need to target very specifically. You need to decide what are your goals and what are your objectives for your project, and then you need to design ways with discrete data streams to make sure that you are targeting the patients that you think you want to target. Once you've done that, you need a very specific workflow. So within the primary care office that we're working with, we do an extensive intake. Once the data has triggered a visit to the patient, we do an extensive intake where we figure out what the drivers are, what the patient's goals are, and then we figure out their level of readiness to change using motivational interviewing. And this is, Prochaska's model of change. And if the patient isn't ready to change, then I want a different workflow for them. And for each of the 5 different levels of readiness to change, we're designing a discrete workflow for those patients. And we have a lot of evidence-based interventions for diabetes, but we have no idea how to string them together into a meaningful workflow. Does DSME come first? Does a home visit come first? Does Project ELF come first? Does the community health worker come first? We don't know how all these pieces fit in together to a meaningful workflow. You need deep provider engagement, which is probably the hardest problem. The patients are easy compared to the providers in the delivery system. This is really all a change management problem. This is the most profound change management problem that I know of, and I mean business literature, process redesign, change management. A lot of interventions fail because they don't go deep and not wide. So a lot of public health is 1 inch deep on too many people to make an impact, whereas we try and go very, very deep. 10 or 15 patients in a practice are driving much of the cost, and it's a totally different workflow to focus on them. The problem in primary care is we have one hammer, and we whack everyone with that same hammer, the 10-minute visit. Whether you're wheelchair-bound, diabetic who can't see their insulin and is totally overwhelmed, or you're a head cold, you get the same 10-minute whack. And what we need are differential service delivery models with differential payment structures. We believe deeply that stories matter. If you're going to do root cause analysis and figure out what's broken, you've got to get close to the stories and listen to them. And we're very worried that the patient-centered medical home, as it's currently constructed, is destined to fail. A level 3 medical home could actually drive up costs. and it should be a seal of approval that you are guaranteed to lower costs, and it's not currently. There's only one workflow that in the short term will save money, and that's a care coordination workflow. So Susan, thank you so much, and I pass it back to you.
Thank you so much, Jeff. Really, really interesting. And now we're duly aware of another deficit we face in this country, which is the delegation deficit, inability of all of us to delegate responsibilities to the next lower level. So we're going to move on to hear from Marshall Chin, who's going to focus on the clinic to community part in particular and speaking to the integration of clinical and public health. So Marshall, over to you.
Thank you, Susan. I'm going to share some of the work we're doing trying to improve diabetes care and outcomes on the south side of Chicago by integrating the work we do in the clinic with what we can do in the community. So Chicago is a city of neighborhoods, and if you look at the map in the middle of the slide, these are death rates from diabetes, where the redder it is, the higher the death rate. And you can see that the south side of Chicago lights up. So we got a problem on the south side of Chicago, and that's where we're focusing our efforts. I think a lot of us are familiar with the challenges of the inner city, so poverty, food deserts, mistrust of populations of the healthcare system, but often we overlook some of the great strengths of the city. So in Chicago, for example, many of the African-American population came from the South in the 30s and 40s as part of the Great Migration and developed a great set of social, political, and cultural institutions. And so there's some wonderful community resources available, as well as healthcare institutions on the south side. Next slide, please. This slide shows our conceptual model for our project. And so you'll recognize the middle is Ed Wagner's chronic care model. Where you see the heart of Ed's model is the integration of community and healthcare systems. And our overall project has 4 different components. So if you start at the upper right, for quality improvement, we're working with 6 clinics, 4 of which are federally qualified health centers on the south side, to work on improving diabetes care through quality improvement initiatives and implementation of care coordination efforts. There's also provider training, where we're training providers in communication skills as well as helping to facilitate behavioral change in patients, using, for example, as Jeff mentioned, some of the principles of motivational interviewing. There's also patient activation. And so the co-leader of this project is my colleague, Monica Peak, and she has a wonderful program where she has developed culturally tailored diabetes education and shared decision-making programs tailored primarily for the African-American population on the south side of Chicago. And then the last part are community partnerships, which I'll talk about now on the next slide, please. So I'll give you an example of a community partnership and its integration of what we do in healthcare with what can be done in the community. So CLEO, K-L-E-O, stands for Keep Loving Each Other, which is a social service agency on the south side of Chicago. And as one of their activities is that once a month they have a food pantry. And unfortunately, there's a lot of clients of CLEO that need to have the help then with the food, access to food. But there's a 2-hour period while the clients are waiting for the food to be distributed where there's an opportunity to do a variety of health promotion activities. So, for example, we do health education where we'll talk about diabetes, or we'll have cooking students from the local community college come in to teach culturally tailored recipes that are healthy for the food that's going to be given out at the food pantry that particular day. We do health screening. So, for example, the picture in the middle right there is one of our medical students doing some blood glucose screening of patients or clients at the CLEO. Then patients who don't already have access to medical care, we link them to a medical home, generally one of the federally qualified health centers or safety net clinics on the south side. And then we also try to integrate this community partnership with some of the other parts of our overall intervention. So, for example, on the bottom right-hand slide, the man with the orange shirt, he's the person that's in our patient classes that's taking Dr. Peak's culturally tailored patient education and shared decision-making program, and he's also then at the food pantry. So the idea is then if we can teach about healthy foods and try to find ways to increase access to healthy food in the community, that people will have a better chance of succeeding than if we didn't have that type of linkage. And then finally, we're doing some food prescriptions. So South Side is a big food desert area, And so we're collaborating both with some farmers markets as well as Walgreens. Walgreens is putting into a number of their pharmacies on the south side healthier food options. And so we have these food prescriptions accompanied with coupons that decrease the cost then of the food at the farmers market or at the Walgreens. Next slide, please. I'll end with a slide on some of our lessons learned about partnerships. So first is what Susan and Noreen both said, that really the healthcare and community integration is the future. One example being the rise of ACOs. We'd recommend starting small, focusing on participants' priorities, and then building from there. And then it's critical to align with others. It's been truly heartening that there's been tremendous enthusiasm from everyone, whether they're patients, the community partners, our healthcare partners. And I think part of it is that people realize it's the right thing to do. I mean, it's the logical thing to do to think about acting both in the community as well as in the healthcare system. And then finally, the integration is time-consuming and challenging, but the payoffs are substantial. And I think part of it is that I think we feel that we are truly addressing both some of the immediate concerns that we need to address in the healthcare setting and the clinic, but also some of the underlying social determinants that we can have sort of long-term success that's sustainable. So thank you, Susan.
Thanks so much, Marshall. And it's great to hear that there's enthusiasm from all, including the providers in Chicago. I'll look forward to talking about that a bit more later, and particularly contrasting it with what Jeff said, which is that the patients are easy compared to the providers. So we'll explore that with a little bit more depth later. So now we're going to turn to James Walton, formerly of the Baylor Healthcare System, and now, as you heard, of course, he's got a new job, but is carrying up through to his new job a lot of learnings from the former one. So, Jim, we'll turn things over to you.
Thank you, Susan. I'm going to talk a little bit about the Diabetes Equity Project that we labeled within the Baylor Healthcare System that was funded through the Alliance. So go to the next slide. I'm a general internist by training, but have been administratively responsible for underserved populations for about 15 years within Baylor Healthcare System before I recently changed my role. The goal of the Dallas project when we were working with the Alliance was really focused on optimizing primary care for chronically ill diabetics. We had a nexus of primary care clinics in the Dallas community that typically had served charity patients on a kind of a free or very significantly reduced fee service. So really we would create that as called affordable primary care. These were not federally qualified health centers. These were organizations that had sprung up in the community to help address the unmet needs that were popping up in our community. Our project focused on at-risk diabetics, and you've heard this already defined very well by both Marshall and Jeff as the patients at risk due to racial and ethnic and socioeconomic variables that create a risk for morbidity and mortality due to diabetes. They're also at risk due to the health literacy and limited English proficiency, and they're also at risk due to marginalization within the larger society, just not knowing really how to navigate kind of the complexity of the healthcare delivery system. And I would say many of us that are not racial ethnic minorities would also say we're at risk because we don't know how to navigate particularly well the healthcare delivery system. But finally, and I think Jeff touched on this, was this idea of at risk due to the primary care capacity constraints. Not only are the capacity of time, but also understanding how to redesign the workflow within a primary care practice to address these variables that put people at risk for morbidity and mortality, particularly around the diabetes disease. Our optimization process was principally to add a team member to the primary care clinic. We called these folks diabetes health promoters, but they're community health workers. They typically have a medical assistance education. That means they've had a high school education or a GED equivalent with more medical assistant education, and then we trained them in diabetes health promotion. Second thing we did was we added a software, and I think Jeff started to touch on this, but I would go deeper into this, that we added a care coordination specific software that focused on the data capture, two-way communication between the care coordination care coordinator and the physician. And then finally, we adapted the primary care workflow. And as Jeff was indicating, again, the care coordination and navigation is foreign to primary care physicians, and they have got to understand what that means to them as how they change their day-to-day work with this new workforce. Focus specifically on care gaps and the behavioral and social variables that constrain the patients around managing their diseases. I'll go to the next slide. Can you go to the next? There you go. So what I want to kind of spend my time with is just to focus on some of our measurements. And as I illustrated on the previous slide, we really were focused specifically on how would we quantify the IOM's triple aim of quality improvement, patient experience improvement, and cost and utilization improvement. And so when you look at the quality work that we were able to document, we had sustained 24 months improvement in disease control by adding these activities to the primary care medical home in Dallas. I think the elements that we would speak to that we probably think that is being affected here, the medication and diet adherence, access to information for patients that didn't quite understand or have access to the information they needed on how to manage their disease and what was the effect or side effects of the medications. But I think that bigger than that is this notion of a relationship with a primary care team, almost as if the patients became VIPs in the healthcare delivery system, and a cultural bridge was established, reducing marginalization of both the patient and the family members with a chronic disease like diabetes. Go to the next slide, please. On the efficiency, we would say that we helped, and we did this brief study within our Baylor Healthcare Delivery System utilization of patients within the Diabetes Equity Project, and showed that the reduction in use and total cost per year of the emergency department, as well as inpatient utilization on length of stay and total number of days and total cost of patients with diabetes that had been selected to be put into this program. And as Jeff was illustrating, or one of the comments he made was, it really greatly depends on how much risk these patients present to the organization for complications. And so the primary care physicians know best which patients to push into this type of solution. So the primary care plus care coordination, I guess, is what we would say this had an impact on solving problems before the hospital. So the patients actually had somebody to call to talk about the symptoms and the complications that they were starting to experience long before they needed a hospital or a specialist. And so at the end of the day, the care coordinators function as intermediaries between the patient and the physician, helping to kind of dissect the problems that they're experiencing. And finally, we did this point of service satisfaction tool. Really, we started this as a management tool for our new health workers, that we would give the patients an opportunity to give feedback on every visit in order to help improve the care delivery of our program. The clinics that we embedded the community health workers in also use Press Ganey for more structured patient satisfaction, but there's really language and literacy and limitations on the number of Press Ganey surveys that we can get back. Go to the next slide. So 3 lessons and that I would comment on is number one is that there needs to be a commitment to the vulnerable population experiencing disproportionate morbidity and mortality. And in a city the size of Dallas, there's like Chicago and Camden, it's a target-rich environment. We would say that creativity has been definitely rewarded over the last 4 or 5 years as our primary care physicians teams have been expanded, and the patients more closely connected to the primary care physicians through the Diabetes Health Promoter. The care coordination software development is really what is needed. We need to develop a more robust software product that helps provide two-way communication and helps to structure the workflow for our community health workers. We have a version 1 IT solution, but we need more advanced solutions. The structure really enables a checks and balances. We were talking about this delegation problem we have in healthcare. The structure of the IT solution can provide checks and balances that enable this delegation to take place, because it creates trust between the patient, the care coordinator, and the primary care physician. And this, at the end of the day, provides more time. And then finally, our last lesson, I would say, would be our nurse management, is that we really believe that our community health workers, diabetes health promoters, have been successful because they've been under the leadership of a nursing infrastructure that really focused on patient care. We know this is an emerging workforce within the healthcare delivery system, and they need a meaningful docking in point that gives them professional integrity, and so they would continue to develop. The constant redesign and team building, I think, that we were able to accomplish there in Dallas has made a huge difference, because it's helped us maximize the efficiency of how many patients each community health worker could manage in any one month, and with an eye towards sustainability and scale. So I'm going to stop there, Susan, and give it back to you.
Well, thank you so much, Jim, and thanks to all three of you. So just to quickly summarize the common themes here, I think all of you, in a way, started with the point that it takes, first of all, the commitment to serving the vulnerable population. And Jim, as you said, in your area, it's a target-rich environment. In all of your areas, it is that. But it starts with a commitment to reduce disparities and identify these patients. And that leads to the second important point all of you mentioned. It's targeting these patients who are very much at risk of suffering from disparities in the system, and actually identifying them specifically and understanding their needs. You all identify the role of data and technology in doing this, and you've all identified the need for even more robust systems of care coordination or what have you. The systems have to get better. They're good, but they have to get better. You all talked about the need for a new level of support within the system, whether it's the AmeriCorps volunteers serving as a health coach or the community health workers in Dallas, coordinators, really new roles that we're creating in the system. And Marshall, I loved your guy with the orange shirt who seems to do just about everything to connect people in the community with various things that they need. All of you have addressed the need to focus on the care gaps and the need particularly for new relationships to develop with among providers to do that, to address those gaps and to delegate down where necessary, but also to just have a commitment, again, back to the first point, to work together across these silos that Jeff's slide so vividly showed to really make a commitment to addressing this vulnerable population. So terrific overview from all three of you. I just want to take a quick point to stop and ask Maureen, we wanted to leave plenty of time for questions. Should we have some more discussion among the panelists, or should we go directly to audience questions at this point?
I think it would be well for you to have a little bit of discussion amongst yourselves. We'll get to as many audience questions as we can, and we'll certainly respond to everybody who puts forward a question.
Okay, terrific. Well, let's drill down on just this point that Jeff raised, that the patients, for all of their concerns, their issues, are easy compared to the providers, and this issue of culture change. What do we do about that? There are no pills for this. There are no executive MBA courses, and you can go away for a week and come back with your culture change. How do we deal with this? Jeff, let's start with you.
I'm sorry, I had you on mute. We're going to need to cultivate new clinician leaders. If you look inside of a lot of hospitals, the clinician leaders were the rainmakers. They were highly paid specialists who often had very strong personalities, and they are going to become cost centers, and I don't think they've got the aptitude for creating a very different delivery system. In the future, all the quick costs are going to be care coordination programs that are deep engagement with patients, and that requires a really different mentality and a really different approach. So first of all, we're going to need new leaders, and we're going to have to elevate up a new model of leadership in clinical settings.
Jim, what would you say?
I think that obviously the emergence of the new financing mechanisms, whether they're through Medicare, Medicaid, or through some commercially involved products, will bring out the new leadership that is going to look for this magic leadership around improving quality and improving efficiency in care, because there's going to be rewards or the significant financial rewards. And I think that's really what we're starting to see is this convergence, if you will, of as policy reform starts to reimburse us differently, then we'll have this more energy behind emerging leaders to drive the change.
Marshall, any thoughts on that?
Yes, people talk about the difference between intrinsic motivation and extrinsic factors, and I think you probably have to have both. So intrinsic meaning people doing it because they want to do it, and I think people do want to reduce disparities and do service to all populations. But it takes leadership to say that, again, this is important and part of the culture that will do it. But I think for it to be sustainable long term, there do need to be the changes in the financial incentives and reimbursement to allow it to be sustainable. So I think both are important.
Let's talk a bit more about the role of these new ancillary personnel. And actually, that's a terrible phrasing because they're clearly not ancillary; they're integral. Whether they're the coaches, the community health workers, the coordinators, how do we move forward? I think, Jim, you had on one of your slides professional development of these community health workers. How do we move forward on that topic in particular, Jim?
Yeah, I think it's a really important point. I've just seen a lot of questions coming across the internet during the call here around where are the CDEs, where are the dietitians, where are the social workers. And what we're trying to introduce here is that they're fully engaged. Those other ancillary workers have been engaged. I think what we're working on with the community health worker model in our work is this intimate relationship between the team, that is the patient, the community health worker, and the physician, or the nurse practitioner or PA. But the point of the matter is this professional development of this new worker who can build the bridge, the cultural bridge, to affect these variables that doctors and nurse practitioners and others don't really have time to do. And so our infrastructure of our healthcare delivery system has just really never entertained the idea up until recently that there needs to be another type of worker that can join in and help address some of these variables, the social variables, the behavioral variables that are so key to controlling chronic disease. So I think it is a team. It's a complex team, but I think we're just at this point saying we need to add another person embedded in the primary care office to help navigate us. And I think Jeff's map was really good about that, his care map.
So
Jeff,
Susan, let's take, just in the few minutes we have left, a couple of questions that have come from the audience and directed to you, Susan, and to Jim and Jeff and Marshall. One that I think is an interesting one, since all of our colleagues have talked about data-driven service. What's been your experience when you've tried to share data in overcoming HIPAA requirements?
Jeff, do you want to address that?
This is Jeff. HIPAA is the poorest understood law that's ever been written, and it's used as a club to prevent collaboration, and it's used in a very defensive way. We have 2 full-time attorneys, which it's really painful to raise grant money to hire attorneys, but you need them because I need to out-attorney the other people, on the other side of the table. So, I think we've been able to get data because we've isolated our work to the city of Camden. No one's fighting over more market share in the city of Camden. We have a really concrete reason for it, and we've built up a lot of trust over many years. And we start small. We do a great job with a little bit of data and prove that we won't cause breaches or be irresponsible, and then you can get more data. So it's, our approach to this is very gradual trust building, and the currency for getting data is really trust.
Great, thanks. Susan, here's a question for you. Do you see any possibility in healthcare reform, its various planks, to create this discussion between the clinical team and the public health team?
I desperately hope so. As we know, not a week goes by that we don't see further evidence of this just stunning, I call it the national health deficit. It is, whether it's contributions to premature mortality before age 50, the data continuing to come out on that, whether it's just ongoing clear awareness that Americans across the board have lower life expectancy than in our peer countries. Unless these linkages are formed and unless we truly buy into this population health model, no amount of improving the efficiency of the delivery system is going to forestall the huge growth in national debt that others have mentioned, let alone just deliver on the hope and promise of a healthy population. So I think we're just a long way from these linkages, but at least now we're beginning to, the business case is obviously, if you will, is starting to emerge, that these linkages are critical, and we start to see pockets of this as people administering ACOs now begin to call into their meetings the public health officials in various communities and start to really drill down on what they can do to increase the inherent health of the population, let alone be the people driving the ambulances better to care for the population that is already sick.
Thanks. So, Marshall, here's a question from our audience. Can you speak a little bit more about the way in which you've connected this more invigorated patient diabetes education with resources in the community, for example, food prescriptions and other ways in which you've created incentives for the connection?
I'll give you a couple more examples. So we talked about the food prescriptions with the farmers market and the Walgreens. Another is that when we teach about healthy eating and we teach about then reading food labels, as opposed to doing it in the classroom, we do a tour of Save-A-Lot, which is the low-cost grocer in many of our neighborhoods. That's the low-cost member of the Jewel-Osco chain. But we then have patients basically shop and then practice reading food labels, and so it becomes very much active adult-centered learning as opposed to being dry in the clinic and divorced from what's happening in the community. Physical activity is another example where initially on the south side is safe places to exercise, and so there's a program that involves the Chicago Park District where providers can give 3 or 6 month prescriptions for free so that patients with diabetes can use then the department Park District facilities for free. There's also, some of you who have been tourists in Chicago will remember the Museum of Science and Industry, and there's a walking club that meets there that will then walk in good and bad weather either around or in the Museum of Science and Industry, and so many of our patients are attached to that also. But again, this is a couple more examples then of partnerships with the community.
Thank you so much. Well, I think we're almost at the end of our time slot here. I want to thank Susan and Jeff and Jim and Marshall for an extremely enlightening and useful discussion, very, very helpful. Also, thanks to all of you who sent in questions. As I've said already a couple of times, we'll get back to you with very specific answers. And I wanted you all to know that the archive of today's webinar is going to be available on our website reasonably soon, and you have the web address in front of you. You can also connect with us on Facebook and Twitter, and we hope that you will share your experiences regarding reducing diabetes disparities in general, and also particularly about how you see we can forge a connection between what's happening at the local level, sort of on the ground, real life, day-to-day experience, and policies in the larger arena that are that have some potential for helping us do our work more effectively. I also hope that you will look at the Alliance website and search for the policy considerations document, which lays out in more detail some of the important ideas that our colleagues have touched on today. Thank you very much to everyone for being with us.